case for keto is just that it works. You eat a ketogenic diet, which is basically abstaining from carbohydrate consumption and replacing the calories with fat, and it puts a lot of different disease states into remission.
Welcome back to Metabolic Mind. I'm your host, Dr. Bret Scher. Metabolic Mind is a nonprofit initiative of Bazooki Group where we focus on the intersection of metabolic health and mental health and metabolic therapies like ketogenic therapy as treatment for mental illness. Today, we're continuing with a series of interviews we did at the 8th Global Symposium on Ketogenic Therapy, and the keynote was given by Gary Taubes. Now, anybody who's been involved in the world of low-carb nutrition or ketogenic therapies is likely no stranger to Gary Taubes. He's the author of a number of different books, including Good Calories, Bad Calories, Why We Get Fat, The Case for Keto, The Case Against Sugar, and now Rethinking Diabetes, which is really a tour de force of a history of the treatment of diabetes and how low-carb nutrition and ketosis sort of fit into that picture of treating diabetes and how that's changed over time. Now, you could say, well, isn't Metabolic Mind about mental health and treating mental illness? Why are we talking about diabetes? Well, what's so interesting is the history of low carb and keto and how that's changed over time, I think applies to any form of ketogenic therapy, whether it's for epilepsy, whether it's for cancer, whether it's for mental illness, or for mental health in general. Knowing this history and knowing sort of the barriers that nutritional interventions and ketosis comes up against, I think really helps us better understand how to help people learn about ketogenic therapies and whether it's the proper treatment for them. So I enjoyed this interview with Gary Taubes. As always, he's a masterful storyteller, and he loves to share his information that he's learned because he is a phenomenal researcher, really digging to learn about the history of things. But now please remember, our channel is for informational purposes only. We're not providing any doctor-patient relationship or any group or individual medical healthcare advice. Changing your lifestyle or medications to treat a medical condition can be dangerous if done without proper supervision. So please learn from our channel, take the information back to your healthcare team, but don't make any changes on your own without consent of your healthcare team. All right, so if you want to learn more about Gary Taubes, you can find him on GaryTaubes.com or on Twitter or X at Gary Taubes. And if you find this interview interesting and want to learn more, make sure to check out Gary's new book, Rethinking Diabetes: What Science Reveals About Diet, Insulin, and Successful Treatments. Well, Gary Taubes, thank you so much for joining me here at the 8th Symposium on Ketogenic Therapeutics.
Thank you for having me, Bret.
So you gave a very good talk to sort of kick things off yesterday at the conference, and I think it really ties in because the title of this whole conference is, has ketogenic therapeutics. So it's talking about therapeutic interventions. And so what you presented had a lot to do with the therapeutic intervention of carbohydrate reduction and carbohydrate restriction. So, some people may think, oh, it's kind of a new thing using, diet as a therapy in this way, but actually no. And that's a lot about what you presented. So give us a little snippet about what you uncovered about the therapeutic use of carbohydrate reduction.
Okay, so, and a lot of it, I can't get credit for, but it's interesting is that Dr. John Rowe asked me to speak about, originally it was the case for keto. And I said, well, the problem, the case for keto is just that it works. You eat a ketogenic diet, which is basically abstaining from carbohydrate consumption and replacing the calories with fat, and it puts a lot of different disease states into remission. I mean, I even think now with obesity, for a lot of people, it kind of puts obesity into remission, or at least excess fat accumulation. And this has been known for, in the obesity field since you could argue 1825, and diabetes from 1797 until 1914, the standard of care was called the animal diet, which was basically fatty meat and green vegetables that were boiled 3 times to get the carbohydrates out. That was embraced and promoted by the leading diabetes specialists, basically in the US and England and Germany and France and Italy, anywhere you look. And then in epilepsy, as of 1919, 1920, it was known. So the case for this thing is it works. I mean, not for everyone necessarily, we don't know, but certainly in epilepsy, it's the percentage of people, the proportion for whom it helps is better known. So the case is why 100, 200 to 150, whatever. Why for centuries is this so difficult to get people to buy into? And that's what I wanted to talk about at the meeting. So I called it the stickiness problem, in honor of Gladwell's term. And why it's, when you have something that's so clearly effective, why does it remain kind of fringe or very much a minority approach to this problem?
Well, I think a big part of that answer is, when it transitioned from being like the care to being sort of fringe is the institution of medications to sort of do the job. So tell us what you uncovered with that.
Certainly in diabetes, as soon as insulin is discovered in 1921 and insulin therapy begins in 1922, it is seen, it is a miracle cure. It's close as medicine has ever had to a miracle cure. So you had these kids back then. The physicians understood that there were basically two general forms of diabetes, which was type 1 was an acute form that struck children, and this sort of chronic form that associated with overweight and obesity and increase with risk with age. But by the time they often diagnosed somebody who we would call say had type 2 diabetes, their pancreas was failing. They would be diagnosed because they lost a lot of weight. They were hungry and thirsty all the time. So for type 1, insulin comes in. It's a miracle cure. And suddenly the discussion about the disease goes from a discussion about sort of the diet-disease relationship to the drug-disease relationship. And now diet becomes an adjunct just to how do you manipulate diet such that you get the best results with drug therapy, which is insulin. So you immediately have to give, this was one of the revelations in my book, is that hypoglycemia, low blood sugar, didn't really exist as a medical condition until insulin's discovered, and then it's a response to insulin overdose. And it was known as insulin overdose or insulin shock in the early years. And now you have to give carbohydrates. And it's easier to balance, to control the disease for at least the physicians and apparently for the patients if you sort of increase the dose of insulin and give carbohydrates to cover it. And physicians start arguing by 1924, 25 that certainly with children it's just easier to give them a lot of insulin, a lot of carbs, and than it is to try and balance it. Whereas Elliot Jocelyn, who's sort of is the dominant, most influential thinker in the field, is saying keep insulin low and keep carbohydrates low and keep calories low, and that's the safest way to do it. But it's not easy. And Jocelyn had his own center where he was seeing hundreds of patients a year where everybody else might see, they had to think about how to prescribe these, some physician in the Midwest, for instance, who might have 2 diabetic patients, that's an entirely different world than being at Jocelyn's clinic in Boston.
So it was the 1920s years.
This is the 1920s.
Keep insulin low, keep carbohydrates low, and then that's how you control diabetes. But I'd imagine in the 1920s, it was in some ways more challenging, in some ways easier than it is now. So to try and say, let's compare where we are now to then, there's probably less ultra-processed foods, less, convenience stores where you could get food 24/7, but also sort of maybe less understanding about how to make low-carb, high-fat meals and how to cook it, prepare it.
And that was one of the issues, which was kind of, in preparing for this talk, I decided to learn about the history of epilepsy and ketogenic diets and epilepsy. And the way I'd always conceived it in my head, based on nothing, was that here was a treatment that was used in the early 1920s and popularized by Russell Wilder at the Mayo Clinic, and then it kind of vanishes, and then these people at Hopkins find it, and turns out that was just wrong. So it's it's true that Wilder was the first one to use ketogenic diets. It comes out of, there's two Frenchmen write a book in 1911 arguing for the efficacy of fasting in epilepsy. And apparently with some children, if you fasted them for 2 weeks or a week or two, completely their seizures would go into remission. And there's a pediatrician at Columbia named Raoul Guyelin, Guyelin, who has a nephew who is epileptic, a young man, and being treated in Minnesota, whose disease goes into remission, where an osteopath in Minnesota is using this French method and fasts him, and the nephew gets better. So Guyelin tries it himself with a patient in New York, and the patient improves. But the problem with fasting, right, is you can't do it for life. And by 2021, they were aware that ketogenic diets basically mimic the fasting state. In both of them, your body is fueling itself on fat and protein. But one, it's fat and protein from your body, and the other, it's not necessarily, it can be exogenous. So Russell Wilder then publishes this ketogenic diet therapy. So that's all true, but it never goes away. Yeah. I imagine that it didn't catch on. When you read the articles over the years, and every year or two there's an article or two on ketogenic diet and how it might work, and they're always saying this is an approach that's used. So people study it because it's out there, it's being used, but it never spreads. And then once drug therapies in the 1920s, the drug therapies are basically sedation, and these children are often put in, mental hospitals or asylums. And you could imagine how awful the experience was in the treatment, but then they would just be sedated so that the seizures could be subdued or controlled. And clearly, this is something Guyelin wrote in 1929. It's like the ketogenic diet didn't work on everyone. But what they would see on a few people, they saw no other treatment, no other therapy. And then, and this is true of obesity, diabetes, and epilepsy, basically all of medical science. After World War II, the NIH, so the first NIH institute is the National Institute of Cancer, and I think it was 1937. And then the Heart Association is originally the National Heart Institute, started about a decade later. And now the NIH post-World War II becomes this major source of funding, and their money they put into research goes up every year, and the research community goes up, and all these young men and women who had been involved in World War II go into medical research, and all these fields are kind of reinvented, and a lot of it is targeted drug therapy, and drug companies are funding research, and as you get more and more drugs, every new drug just seems easier to use for the physician and the patient than trying to teach them how to do this diet, how to do it correctly. Nobody's really thinking about it deeply. It only really catches on. Like in diabetes, it's now pretty much vanished. And the other thing that's happened is you get people arguing that dietary fat causes heart disease. Yeah. In the diabetes field, goes back to the 1920s in the US. In heart disease, it's the 1950s, the Ansel Keys story. There's always a reason not to try these diets. There's always something that seems scary and terrifying, and they're hard. They appear to be hard work. Back then, they're poorly thought out. There was an article in 1923 in a journal, the physician talking about watching his patients eating basically baseball-sized pieces, chunks of butter. I think I mentioned in my talk, there was a Swedish diabetes specialist, I'm going to forget his name, who also sort of perfected this ketogenic diet for diabetes, and his was very high fat. He wouldn't even let his patients have bacon because there was too much protein in the meat and the bacon. So basically they were living on butter and cucumber slices, which have very low carbs. And the Germans, Petron, that was his name, and the Germans commented on this, said they just, it was very effective. Like if they had patients, even patients they had trouble controlling with insulin, they could control with this ketogenic diet, but they just somehow the Swedish diet was considered so high fat that they would embrace, Bundes, and the Germans would never do it.
I think it's so great to get that historical perspective, though, because people could say, people are skeptical of new treatments, and rightly so, right? Until something's been borne out or been studied or had more experience, until you know what's really going to happen. But as you've been digging into this, it's hundreds, one or more hundreds of years of experience with this. But like you said, it sort of waxes and wanes with the medications and with concerns about the diet. So the other thing that you've researched is this concern that fat equals heart disease, that if you have a fatty diet, sure, it might control your seizures or control your type 2 diabetes, but you're going to die of a heart attack. And so since you've been involved in this whole field and researching this, what's your perspective on that fear?
Well, clearly, I don't think it will. Hope not. I often, when I give advice myself to friends or people who come to me, I say, this is how I think you should eat. I think it's benign, and if I'm wrong and have a massive heart attack, I apologize in advance. I could do that as a journalist. It's harder for a physician to do in public health organizations, and governmental organizations can't do that at all, or won't do it at all. But there was always this, the idea that cholesterol was involved in coronary artery disease dates to the 1870s, and famous, German pathologists discovered cholesterol in the arteriosclerotic plaques. And by the 1920s, the idea is that high-fat diets might precipitate this, because we're also finding fat in the plaques. It's fatty arteries, basically, and you eat fat, and it's very simplistic.
Right.
One of the lessons that came out of the diabetes book that all my work has been about good science and bad science, and I'm always fascinated with how science goes awry. And the initial problem is always sort of thinking you know the answer when you don't. Okay, so we talk about falling in love with our hypotheses, but it's often having only one hypothesis as a problem. And the hypothesis that comes first has a huge advantage, and it's usually dependent on the technology that's available at the time, and the technology is often very primitive. So for instance, in obesity, the only seemingly related technology was calorimeters that allowed you to measure energy intake and output. You couldn't measure the hormonal response to different foods you were eating, or even the hormonal responses at all, for a century after you can measure energy intake and expenditure. So this energy balance theory in obesity that we get fat because we eat too much came about in part because it seemed to make sense. And the only variables we could study relative to obesity was energy balance. So there's your theory. And heart disease, this idea that fat, that it's caused by cholesterol accumulation in the arteries and fat accumulation in the arteries, and therefore high-fat diets, that was the first hypothesis. They saw the cholesterol.
Right.
Makes.
But just because seeing it there doesn't tell you how it got there.
Doesn't tell you.
Once the assumption is it's from eating fat, and that's the hypothesis, you're saying that's what dictates the rest of sort of the theories and the research and the interventions, because it was the leading hypothesis.
And then you've got very limited tool sets. So for instance, in the 1920s, Elliot Jocelyn, here's another fact we don't take into account. So ideas tend to be set when fields are small, and I talked about this in my talk yesterday. When you have a large signal-to-noise ratio, and they tend to be established by dominant figures in the field, and you hope that those dominant figures are brilliant. In physics, for instance, people, you can take away people like Einstein and Schrodinger and Bohr and Fermi, and you don't have a revolution in physics in the 20th century. There's no, atomic age with all the good and bad that went with it, because you removed the 4 people who were smart enough to figure this out. In molecular biology, you take away Francis Crick, and you've got, we don't know what DNA is, So it's sort of, we tend to downplay the role of these dominant personalities, but you can also have fields that are dominated by people who aren't smart enough to solve the problem, or aren't critical enough. And Elliot Jocelyn had the first diabetes clinic in the United States, first clinic dedicated to diabetes. And he was a wonderful clinician, wonderful doctor, but there's a difference between thinking like a doctor and thinking like a scientist. They're 2 different cognitive skill sets. Because he's got the first clinic, he's seeing more patients than anyone else. He also must have had extraordinary energy and focus. So in 1916, he writes the first diabetes textbook based on what I learned from 1,000 patients. I forget how it's phrased in the subtitle, but it's experience from 1,000 patients. His second edition is experience from 1,300 patients. His third experience, and the edition 1921, is 3,000 patients, and it goes up and up. The 14th edition of Jocelyn's textbook is what's out there now. So Jocelyn dominated thinking. It was the only textbook out there. Even in the UK, the leading diabetes authority, R.D. Lawrence, who had type 1 diabetes himself, talked about the great book of Jocelyn, because that's what you read. Nobody had ever done anything like that before. I mean, there had been British textbooks and German textbook monographs on diabetes.
Well, but based on that, though, then carbohydrate restriction should have been the leading hypothesis.
It should have been, but Jocelyn embraced calorie restriction in 1914. This idea that you semi-starve patients with type 1 diabetes, it's not just the carbohydrates that are the problem, it's the carbohydrates and the fat and the protein. It was an idea by a colleague and friend of Jocelyn's named Fred Allen, who had written a 1,300-page monograph, and based on everything, extraordinary amount of research on the history of the disease, the different ideas, and then he had done hundreds of animal experiments. And from animal experiments, he concluded that dogs that had their pancreases either removed or partially removed could be kept alive better with semi-starvation than with carbohydrate restriction.
You certainly do thorough research, no question about that.
It's because you really want to understand. Richard Feynman, the physicist, made this point in his gave a famous commencement address at Caltech about good science. You have to know why you believe what you believe.
Yeah.
Particularly, ideally everyone would do this, but most people don't. Who has time? You can't even, nobody has time to keep up with what's being published now. This wave of noise that I described, the hundreds and hundreds and hundreds of articles a week published on whatever subject you should be interested in.
Most of which are observational studies that don't...
most of it is just noise. I just came from a meeting in Copenhagen. I was telling you about it. Novo Nordisk is looking for ways, obesity research to fund, and one of their programs was to fund, to give out the equivalent of NIHR1 grants, so $500,000 a year for 5 years. And I don't believe you can do meaningful research to solve this problem with those grants. It's like as soon as the size of NIH grants and the pressure to publish this we can go on for hours.
Yeah.
But
well, your experience at NUSI, I'm sure, has taught you many things, one of which is how expensive good quality research that is going to directly inform clinical care.
Well, it's also...
when you put those qualifiers, it gets very expensive.
Yeah, and how easy it is to screw up even an experiment like that. Yeah. So basically, I felt this way about my talk. You give a talk, I notice as I'm giving it what I should have said, what I shouldn't have said, what I had to set up better. It's like it's an experiment, and maybe this will work. Oh, well, yeah, it kind of worked, but it kind of didn't. And then if I give it 5 times, I'll finally get it right. The same is true of experimental research. Clinical trials, you do a clinical trial, I guarantee you what you actually learn from the clinical trial is what you should now know to get it right.
Yeah.
And then the second trial might be the same thing. So not only are these trials long and expensive and have to be planned with extreme care, but even then, the likelihood that you've gotten the wrong answer is going to be high, and you will have learned what you have to do next. So one of the points I made about, like, when scientific fields, this is from this brilliant science journalist Horace Freeland Judson, who's called it the golden ages of science, or when the experiments are cheap enough that you can do them and then redo them and redo them and redo them, and eventually nobody could think of a possible way in which you screwed it up. And now you can start believing what you're seeing, and you still have to be, express your results with humility, because maybe when you go public, somebody else will think about how you screwed up. I've interviewed physicists from that era who talked about, like, reading a result in a paper on Friday, spending the weekend in the lab, building the equipment, from like cannibalizing other experiments to build the equipment, so on Monday they could test it.
Yeah.
And then you could find out if it was right, but just because it's out there doesn't mean it's right.
Right.
So.
Replication and checking. And so, fast forward to a lot of what
Let's go back to Jocelyn
Okay.
in the 1920s. The point is, here you had one person with enormous influence, with more patients than anyone else, had never been taught to be a scientist. He was a doctor, a physician, and a wonderful physician. But now you have him kind of dictating what he thinks might be true. And so there are all these issues with this ketogenic diet. So first of all, he had gone from a mostly an animal diet thinking. He had gone to Germany and learned this was what the German authorities believed was best, and he came back. His mother had diabetes, and he kept his mother alive for 20 years after diagnosis. She did wonderfully on this diet. But then he switched to this idea of calorie restriction, where you're semi-starving people, and by the time insulin's discovered, that's where his mind is at. And now, maybe subconsciously, I also want to defend that. So simultaneously, you have this University of Michigan doctor saying, we've tested this. They don't call it a ketogenic diet, but it clearly is. It's 75, 80% fat. And patients do wonderfully. Then insulin comes in. And so the diet becomes, like I said, an adjunct to insulin therapy. And now the high-fat diet seems too dangerous. And then by the end of the 1920s, they start seeing this wave of diabetic complications. They'd never been able to keep patients with type 1 diabetes alive for more than a year or two after diagnosis. The semi-starvation allowed them to push that to 3 or 4 years, maybe, but they were these emaciated skeletal children. The Europeans would come and visit Jocelyn's clinic, and they'd be just horrified looking at these children, like, wouldn't it be better if they passed away? Then you just torture them forever. But they kept some of them alive to get insulin and then live. But now with insulin, you start to see kids with diabetes who are alive for 10, 15 years. You see not only the long-term complications of the disease, potentially, but the long-term complications of insulin therapy. And the combination is pretty awful. It's sort of reading about some of these children, they would write letters to Jocelyn, and because Jocelyn had saved their lives, and they go from being teenagers to now they're in their late 20s or early 30s, and their bodies are they're suddenly, their arteriosclerosis and atherosclerosis and kidney damage and gangrene, and they're going blind, and then back then they died. They could be 6 months from apparent good health to death. So how do you explain the arteriosclerosis? In the meantime, a German pathologist had come through a tour of the United States giving lectures and had spread this cholesterol, dietary fat theory, and Jocelyn had bought into that. And so he could blame what they're seeing on the high-fat diet that the kids ate before, not his kids, but other kids ate before insulin. So there was always a way to blame dietary fat, and Jocelyn just couldn't stop it. In the same textbook, his editions of the textbook read like one of these archaeological digs, because you can find the old stuff is still there, but he adds new stuff, and the new stuff might contradict the old stuff. So in the same textbook edition, I'll talk about how effective, how he knows that these high-fat diets that these Michigan guys, Newberg and Marsh, were pushing, clearly seems to relieve the hypertriglyceridemia or lipemia, the high blood fats and uncontrolled diabetics, but still, it must have been the high-fat diet that caused heart disease. And the last thing he's ever going to recommend is the high-fat diet, but yet the high-fat diet seems to be very effective. And this kind of mindset just infected a whole generation after generation of diabetes specialists.
Well, so taking all that research, right, all that understanding of the past is so important as it can inform our present and our future. So what do we need to do? I mean, what do we need to do to have more doctors, more organizations realize that, again, bringing it back to this conference we're at, Ketogenic Therapeutics, that this is a therapeutic intervention that can be helpful, can be safe, but we have to get from our own biases, our own, single hypotheses, learning from the past to bring it to the future. So what's your recipe?
Well, I think great progress can be made in fields that don't have preconceptions and don't have ideas about, what's a proper diet, how to eat to be healthy. So this one of the things I find so wonderful about Metabolic Mind, and it's the reality of this apparent efficacy of this diet and bipolar disorder and schizophrenia and the other cognitive disorders is there is no conventional wisdom. And drug therapy is so clearly inadequate for so many people, that so many patients, so many physicians or, caregivers are aware that they can keep these disorders sort of controlled, but at a huge price to the, nobody feels good on these drugs. So if you come up with something better, I think it can spread because it won't have the same kind of opposition. Always have these difficulties with people who have to understand the diet, they have to know how to eat, they have to make the effort to know how to eat, although those of us who have made that effort, it's not that difficult. It's not. One of the favorite lines from my diabetes book is a chef who was diagnosed with type 1 diabetes in his 30s and then became a journalist. He worked for the Sweet Life. Originally, he interviewed me for my book, The Case for Keto, and then I said, okay, now I got to interview you for the diabetes book. And he said to me when he was diagnosed and he brought up the ketogenic diet to his diabetes educators, he said, well, it's very hard to comply with. And he said, but here you're pushing me to exercise an hour and a half a day. I mean, that isn't hard to comply with, but just not eating carbohydrates is. I mean, it's sort of, if we push back against some of these tropes that are out there so commonly. But again, in cognitive disorders, there's pretty much an open playing field and an opportunity to, epilepsy, there's dozens of drugs, they work good or bad, for those people for whom they either don't control the disease or the side effects are difficult to live with. I think the ketogenic diet will always be seen as an option. I think, after 100 years... You could argue it should be an option sooner rather than waiting to... we want it to be the first option, right. And part of the messaging should be, look, this isn't... You can see how it's spread through society. Clearly, it's not that hard to comply with. There are people who love it. Clearly, it's not going to kill people. This is what I said in my book, The Case for Keto. We know that it's at the very least benign, not beneficial. Several hundred clinical trials have been done. That's all spreading and out there, and it's having an effect, but it's a slow progression because you're fighting against all this conventional wisdom, the plant-based diet movement, even the environmental implications now. For schizophrenia, bipolar disorder, you're not going to have that pushback. These are, tragic and disabling disorders, and if there's something that works, people are going to embrace it. That's what I'm hoping.
Yeah.
the messaging, you know, I think is just keeping up with all that's changed. Again, a lot of what's happened is because of the internet. The internet allowed us to go around the gatekeepers.
Yeah.
You know, the information got out there. People could learn how to do these diets. They could, you know, you diagnose with something, you Google it, and then boom, there's somebody saying, try this diet. It made me feel better. And one of the revelations from my research is that this stuff always starts with an anecdote. One person who a physician noticed did better when sort of contradicting the expectation that they wouldn't.
Right.
And then,
It doesn't make it science, but it doesn't make it wrong.
well, it's an observation. Science begins with observations, and the observations that are important are the ones that are in conflict with our expectations. So if you see exactly what you expect, you can have 20 people who go on the diet, and 19 of them you see that doesn't help. The 20th, seizures go away or psychotic episodes go away or something. It's sort of, I want to know what happened there.
Yeah. Why did that work? And that's where a lot of the research comes in. And so until the research sort of catches up, the clinicians are left with decisions of how to implement it, how to safely implement it. And that's something that we're trying to do at Metabolic Mind. But learning the history of just carbohydrate restriction in so many different areas, I think helps and should make us feel a little more comfortable that this isn't new. This has been around, and we can learn lessons from the past. So thank you for sharing all that.
Thank you, Bret.